My name is Daniel Diaz. I'm a second-year internal medicine resident here at Kendall Regional Medical Center in Miami, Florida. And I, along with my colleagues, would like to present this case of PRES that we recently saw at our institution. PRES, or posterior reversible encephalopathy syndrome, also known as reversible posterior leukoencephalopathy syndrome, is a clinical radiographic syndrome characterized by a multitude of rapidly developing symptoms. Patients with PRES often experience the development of these symptoms over the course of hours to days and is often preceded by a hypertensive crisis by 24 hours or longer. Populations affected by PRES seem to be very wide-ranging, between the ages of 2 to 90 years old, and predominantly seen in females, making the incidence difficult to determine. The exact pathogenesis of PRES is unknown. However, it's thought to be due to a combination of irregularities in autoregulation mechanisms and endothelial dysfunction, ultimately leading to the disease's manifestation. Conditions associated with PRES include hypertensive encephalopathy, sepsis, acute or chronic renal disease, vasculitis, immunosuppressive therapy, and many more. Metabolic disturbances have also been associated with PRES, including uremia, the aforementioned sepsis, and hypomagnesemia, which was seen in our patient. Our patient was a 93-year-old female with past medical history of hypertension, hyperlipidemia, TIA, and DVT, who presented with left-sided gaze palsy, left-sided facial droop, aphasia, and complete right-sided weakness with an inability to walk for 3 days prior to presentation. On arrival to the emergency department, the patient was treated as a stroke alert and administered a bolus of TPA after CT angiography revealed a 7.7 millimeter aneurysm arising from the left vertebral artery, originating at the right anterior inferior cerebellar artery. The patient's initial laboratory values revealed hyponatremia, hyperkalemia, and a concern for seizures, which resulted in the patient being started on Keppra, Ativan, and intubated for seizure and airway protection. The patient was also found to be, as mentioned before, hypomagnesemic at 1.3. A subsequent MRI brain was notable for resolving diffusion restriction involving the bilateral occipital and parietal lobes, consistent with an atypical presentation of PRES, with an additional evidence of superimposed cytotoxic edema greatly potentiating the risk for tissue infarction, which is seen here in figures 1 and 2. The patient was admitted to the ICU for hyponatremia management, where she was stabilized and eventually extubated, prompting a downgrade to the IMC unit. Despite the efforts to improve her state, including controlling her blood pressure, treatment with antibiotics, and IV fluids, the patient remained encephalopathic, never regaining her baseline mentation. Due to this, the patient went on to develop respiratory complications due to an inability to clear her own secretions. The patient continued to deteriorate, and a chest X-ray showed whiteout of the left hemithorax. Due to the patient aspirating her own secretions, a post-obstructive left lung collapse developed, prompting a readmission to the ICU. The patient was then intubated and subsequently found to be producing copious amounts of purulent secretions through the endotracheal tube. The patient would unfortunately expire from complications. PRES is a condition characterized by the rapid development of headaches, altered consciousness, visual disturbances, and generalized tonic-clonic seizures. These symptoms are typically preceded by the development of severe hypertension in the prior 24 hours. The condition has been found to be more common in women, as mentioned earlier, and affecting patients ranging from 2 to 90 years. However, several case series have documented a mean age of 39 to 47 years old. This patient's presentation of PRES is notable given that she was well above the average age for patients presenting with PRES. Additionally, the MRI findings for our patient were atypical for patients with PRES. In our case, the patient's significant history of thrombosis supports the belief that pathogenesis of PRES is due to a component of endothelial cell dysfunction with increased risk for thrombotic events. In conclusion, this case adds to the consensus that more research is required to fully understand PRES, its etiology, and risk stratification of what aspects make it more likely to be as severe as it is, and, contrary to its namesake, permanent for some, as it was for our patient. The severity of this condition and how it affects individuals further warrants insight into the pathophysiology, treatment, management, and possibly prevention of recurrence in those diagnosed with PRES.